cumulative cases is among our 30 to 39-year-old population currently. Some people do have questions about kids. And so looking at peds, that is anybody 19 and under, or is it, sorry, we're looking at people age 20 and under, sorry. They do not make up an incredible, our biggest group of persons, even over time. But it is interesting to still watch what's going on in that population. For peds, we know that we are also following them by their sub-age groups. So the blue represents those age 0 to 9. The green represents those 10 to 19. And we do know, we can definitely see that we don't have, our biggest group of peds is actually your 10 to 19-year-old peds. That was just a brief overall, basic demographic breakdown of COVID-19 cases, incident cases. But we also have to ask ourselves the question, when we think about incident cases, how much is what we're actually seeing reflective of testing behaviors? That is a question that we have to ask. Are we seeing fewer cases because fewer people are actually getting tested? Are we seeing fewer cases because there's actual decline in the population? And that question can be kind of challenging to answer, especially when testing is not mandatory. So it is a wise idea to start looking at positivity rates. And so basically we're looking at what is the likelihood of finding a positive case, given all the tests that are currently done, RT-PCR specifically, right? So one of my jobs is to look at this information. And so starting from EpiWeek 26, because that's what fits on the page nicely, we noticed that there was a sustained increase in uptake in number of tests, PCR tests conducted. And we have seen diminishing of that testing behavior since EpiWeek 30, which is approximately early August. And since then, if we look at some of this data, it indicates that our highest peak for positivity actually occurred around EpiWeek 35, which is around September, like early September. At 26% of the samples that were tested were actually positive. So that was basically a quarter of your tests were positive for COVID-19. By EpiWeek 43, which was 2 weeks ago, really, that percentage has actually decreased to 9%. So we're fairly confident that what we're seeing is, even though that we have reduced amounts of testing done in the population, we do see that we have a reduced likelihood of finding a positive among those tests. Okay. All right. I'm going to close out with deaths because this presentation was meant to be short. So the first COVID-19 confirmed death occurred on March 31st, 2020. I think that was the lady from Bimini. Since then, we've had 665 persons diagnosed with COVID who had died. And so this number actually is reflective of persons who had a confirmed COVID death. And so the number of persons who had COVID but died of something else is actually different. I don't remember what that number is off the top of my head right now, but we do know that this 665 refers to people who actually died of a COVID-related cause. That puts when we look at our cumulative data, if we put that as a percentage of our cumulative data, we end up with a crude case fatality rate of 2.9%. It varies slightly when it comes to sex. We notice that crude case fatality rate is 2.8% in males and 2.5% in females. What I did not touch on, because it would take a very long time to explain and go through, is age. age case fatality rates. That is actually, it's very interesting when you look at the data, but we have a little bit of tweaking to do, so I'm not going to talk about that too much today. However, it's important for us to actually look at death rates by age in order for us to actually say, how is COVID-19 really affecting various populations, okay? All right, so this is basically a run through of what we experienced in terms of COVID deaths over time. And so, like I said, we had about 600, and don't worry about the spread. The scale is kind of strange with this graph. So, but that number is reflecting around 660 something deaths. And of course, these are COVID-related deaths only. And so we see that basically it looks at it from the beginning of the epidemic, and it fits pretty nicely with our second wave around here. And we've noticed that, and this is daily deaths, sorry. We had our peak number of deaths by day at, I think it was 11 in sometime mid-August. So, so it is going to look slightly different from what you've seen on the dashboard, because we're not going by the date the death was reported. We're going by the date the death occurred. And so you can see it labeled out. You know, we've had substantial a greater number of deaths occur in our third wave than any other time. Particularly between the months of August and September. Okay. Actually, this is just a monthly representation of what I just did. Sorry for that, I was there. But yeah, it's pretty startling that we had over 100, like about 150 deaths in August of 2021 and 153 in September of 2021. Okay. Breaking it down by age and sex, present, just keeping this presentation pretty simple. 51% of our, 51% of our of our COVID deaths occurred among females, while males accounted for 49% of deaths. When we look at it by age group, we notice also that, and our age groups are a little bit thicker, just for simplicity's sake. But our biggest age group deaths occurred among those aged 60 to 79, followed by those aged 40 to 59. Yes, and so basically that's it. Okay, so be careful. I'm just recognizing now that 0 to 19 says 0%. It is not that we didn't have any deaths. I just forgot to put on a decimal point. So I do believe we had, I think it was 2. I'm not sure if it's 2 or 3. If you remember Dr. Forbes, I don't. Yeah, among that particular age group. And that ends my presentation. If there are any questions, I guess you can go to Dr. Forbes, and then you can ask me afterwards.
Yes, thank you very much.
Ms. Johnson, if she has other demands, because she is very much in demand, if you want to take your questions now, I could hold on so that you could be free if you don't want to stay on for the other part.
Okay, all right, that's up to you. Sure, I can take any question. Well, I can take a question, not any question. Okay, well,
I have a question. So I thought it was interesting that it skews like there are more women infected, more cases, when I guess data from a lot of other places shows the opposite, like men, for whatever reason, are more infected. Do you have any idea why that might be in the Bahamas?
It could be health-seeking behaviors, most likely. And so the best bet would probably be hospitalization data to look at it. and see who's, like really, really sick,
Mhm.
Unfortunately, I don't have that information right now. So, it would be interesting to look at it though.
Yeah, cool.
Mhm.
Also, would it be the comorbidities that, you know, diabetes, hypertension, obesity that
Mm.
may be contributing?
It very well could. It's kind of difficult to quantify that information at present. Like I said, you crack the whip on a lot of reporting of, case information. But there are it doesn't mean that they report everything that they're supposed to report. So that information is still being developed.
Okay, all right.
Mm.
Thank you.
Can I just add to that before we wrap up? So that's a very good question because it's not too clear right now who's more susceptible to get COVID. There are probably a lot of factors. So it could be that women are more forward facing. Do more women work? We don't know. Are they more likely to be out and about running errands? Do they get exposed more? That's one thing. Is there a genetic possibility? Are there immune possibilities? Is there something about comorbidities and health and obesity and other things that make people more susceptible? Women are more obese than men. We had, remember, Glenise, we had Colette Myrie in the first wave. You may not have been a part of that meeting. We were looking at comorbidities to see if more people with COVID had them.
Mhm.
So it's not too clear at the moment, but it will get interesting to as we learn more about the virus. But thank you, very good question.
Mhm. No problem.
I move
Dr.
on to my
Thanks.
talk now because I
Yes.
want to get to my talk and go to Chest Clinic on time.
Okay. Dr. Forbes, Dr. Sears is still with us, who gave the first talk.
Okay.
Dr. Kendra Sears from the University of
Good morning,
Maryland
Dr.
School of
Sears.
Medicine.
Hi, how are you doing?
Oh, I'm good, thanks.
Great.
Always good. Great to hear you talk.
All righty, thank you. Nice to meet you virtually. All right, students, doctors, this is not going to be long. Let me just find my PowerPoint slides. And hopefully it will let me share. Yes, here we are. I hope you're seeing my presentation.
Yes, ma'am, we are.
Okay, good. So Dr. Moxie invited me to talk with you all as a part of your community health experience about COVID prevention and treatment. And this is an exciting part of your medical training, community health. And I do want to share a few things before we really get into the presentation. So COVID is a new virus. And that being said, we're learning more about it. And there really is no cure available yet. And what do you really need to know? So that's the key. What are the key objectives? What do you need to know at your level in terms of prevention and treatment? You certainly do need to know the key ways to prevent getting COVID-19 and have an idea about how you approach this across the spectrum of COVID disease. And we're going to talk about that. Now, the treatment area is new and changing. It is bolstered by scientific data and studies and looking at key things that you may have learned about in the epidemiology part and the statistics part of your education, like relative risk reduction, efficacy, reducing mortality. And you don't need to be able to quote those things as a medical student, but you have to have a cogent, sort of comprehensive idea of how this can be treated. And this is going to change, and this changes rapidly. I'm also going to talk a little bit about how not to treat COVID-19 and how you figure out how not to treat something and how you get best quality information. So that's an important part about being trained, because the truth is, who do you listen to? There's just so much information. There's information in the social media space. There's information in the online space that you can search for information. There's medical information that is shared by doctors, and even various doctors have different perspectives And so how do you know what works and what doesn't work? And that's what I really want you to take home from this presentation, and where to go to get accurate treatment information and guidelines. Okay, so I'm not going to drill you down into the minutia. I have a few slides, and then we're going to talk, we're going to go to an internet source. So as an overview, coronaviruses, they are important animal and human pathogens. There are over 200 coronaviruses. And a new coronavirus was emerging at the end of 2019, and that is what we now call SARS-CoV-2, which is the virus that causes coronavirus disease, or COVID-19. We know it's a global pandemic. There are 222 countries that have reported a case, and as of November 10th, there were just about 251 million cases. We have 2.1 million cases in the Caribbean here in this slide. In the Bahamas, the cumulative total as of November 8th was 22,000 cases. And this is only going to go up. COVID is not going to go away. Here is a little cartoon of COVID transmission. And we have to understand this before we start talking about prevention. And so, how can COVID be transmitted? It can be transmitted by droplets. You can see the fellow in the blue cartoon has COVID. That's the little coronavirus particles with a spike in his nose and mouth. And when he's talking, singing, speaking, coughing, singing, those droplets are going to emerge into the air. And they can land on someone who is close by, maybe about 6 feet, 3 to 6 feet. But there are times when this can be aerosolized. It can be in the air for certain periods of time. And so that means that it can maybe travel further distances or even be there for longer periods of time. Droplets. Droplets are larger particles that someone can speak or sing into the airspace, but they are, given that they're a little bigger, they actually drop to the ground. But aerosolized particles don't. They're suspended for some period of time. And so you can imagine it's easier to get sick and breathe that in if it's aerosolized versus something that's fallen to the ground. Okay, so let's talk first about the droplets. You can breathe it in if you're close by. The person can cough on your face, and then you can say lick your lips. If it's on your lips, then you will be exposed. And it can land on surfaces. So if someone is at a desk and sick and coughing, and you come there as a student afterward and you start writing notes, it could get on your hands. And if you wipe your face, you could then be exposed. If something is aerosolized, again, it's suspended in the air for a certain period of time. There are medical procedures that can cause aerosolization, like deep suctioning, chest physiotherapy, intubating a patient, bronchoalveolar lavage, maybe even neb vents. And so we have to think about that in terms of how we prevent getting COVID-19. And then maybe violent coughs and closed spaces. It is possible that it can be aerosolized, and there are even occurrences where people who are further away than 6 feet can be infected. Okay, so that is what we know about the transmission dynamics so far. Now, that being said, then how do you prevent getting COVID-19? And so wearing a mask gets very important, but everybody has to wear the mask. The person who has COVID or SARS-CoV-2 has to wear the mask, and other persons who will be exposed. And just by nature of the fact that some people who have COVID-19 have no symptoms, then everyone has to wear a mask. And there are things about the mask. It has to be a good quality mask. And so there are medical masks, there are non-medical masks. So the medical masks are, for example, the surgical mask that filters about 40% of particles. And then there is the N95 or KN95 mask that filters about 95% of particles. Traditionally, flu, you could use the surgical mask to reduce your exposure to flu. But as I said with SARS-CoV-2, that's a little different than flu. Flu is really spread usually by droplets, so it's going to drop to the ground. But we know that COVID can have smaller particles in the respiratory droplets and secretions that can hang around. And so an N95 mask, especially if you're in the hospital doing aerosol generating procedures, procedures that we just discussed that would be more likely to aerosolize COVID, is what you want to use in that space. Now, certainly those masks could be used outside of the healthcare system. When this first emerged, we were concerned about the global supply of these things for healthcare workers who are really at risk because they're taking care of COVID-19 patients. And so the ask was that these things get reserved for medical and healthcare workers. However, there are many non-medical masks that have emerged that are the same style as the surgical mask and the KN95, and they are available. But you don't need those. You can use a homemade or cloth mask. And if it is well-fitting, it will also protect you from getting COVID and persons from spreading COVID. It should be a cloth mask made of well-woven cloth, for example, cotton or polyester. You don't want to use a lace mask or a crochet mask, because if you can see little spaces in the mask, then air can go through, and so can COVID-19. The mask should fit snugly over the nose bridge, and the face. And it can then be snugly secured behind the ears or even on top of the head. And there should be no spaces between the face and the mask so that there's no air leak, so that obviously if you're going to breathe in air, there can be COVID-19. Face protection and eye protection is also helpful because COVID can go into the eyes. And those are key things. Now, there are other precautions. You want to wash your hands and have good hand hygiene, especially after touching frequently touched surfaces like doorknobs, shared phones, surfaces at work, for example, elevator buttons. You want to avoid crowds and socially distance. If you're in a large crowd, especially with a mix of persons, some may be vaccinated or unvaccinated, and people are not wearing a mask, that will increase your risk for COVID. Now, there are certainly facilities that are more likely to have COVID, for example, nursing homes, healthcare settings. We want to very carefully steward the amount of persons that go into nursing homes. We really have to be careful because that community and that age group is very vulnerable. If they get COVID, they're more likely to die. And so we have to be careful who goes into those long-term care facilities. Cleaning and disinfecting is very helpful. And you can use a bleach and water solution, 1 part bleach and 4 parts water. That will help to kill the virus. And then there are also commercially available disinfectants, of which I have no stakes in, for example, Lysol and those other disinfectants that will also kill the virus. You'll see there are plenty of them, Purell and other things. And at least the alcohol-based hand wash should be about 70%. And there are other things. If you are sick, if you got symptoms of COVID-19, please stay home. Please do not go to work or go and meet up with other persons, because that is exactly how COVID would spread. And when you are coughing and sneezing, you want to cover your mouth and nose, either with a tissue or with the crook of your elbow, for example. Now, there's more to preventing COVID than these key messages. There's also staying healthy. And that certainly does impact susceptibility. So staying healthy means eating a healthy diet, having enough fluids, rest, stress management, and preventing and mitigating things like medical comorbidities, staying normal weight, and things like that. That also plays a very, very important part. That is one part of prevention. Those are the public health measures we've been talking about. The other part of prevention is the vaccines. So let's see. Vaccines, as we know, are therapeutic modalities that will train your immune system to protect you against an infection without having to actually naturally go through the infection itself. I did not decide to drill down on vaccines since we have heard that a lot. And just 2 weeks ago at Research Day, we talked a lot about those vaccines and other spaces. For you to know, and you should know more than the general public, and people will ask you because you're student doctors, there are many vaccines that are available in the global space. In our country, we have the AstraZeneca Oxford vaccine, the Pfizer vaccine, and the Johnson & Johnson vaccine. The AstraZeneca vaccine uses something called mRNA technology, and that is a relatively new technology available in a widely used vaccine, but that's been being worked on for decades. And it trains the cells of your body to express the spike protein of coronavirus transiently so that your B cells can mount a response. AstraZeneca and Johnson & Johnson are called viral vector vaccines. They use a harmless cold virus to introduce the spike protein so your B cells can mount an immune response. And then there would be memory B cells and a T cell response as well, should you get exposed to coronavirus. I'm not going to drill you down into an immunology lesson, but you should know that better than all of us now, since you're closer to basic sciences than we are. So now we're going to move on to the part of the presentation about COVID-19 treatment. In case you have any questions on prevention, I'm going to pause. And I think we have about 25 or 30 minutes left together to talk about this part. Well, if you do not, this is what you need to know about COVID disease. There is a spectrum that goes from mild to critically ill and even dying. And then there's SARS-CoV-2 infection. So let's understand those terms. Infection is the ability to detect the organism in the body, but the person has no symptoms. Whereas disease is a manifestation of a process where there's a pathological process going on in the body, and the person will have symptoms. Do we understand that? So we have to think about that before we start talking about treatment. So persons with SARS-CoV-2 infection, they may be asymptomatic, no symptoms at all, feel perfectly fine. And then disease, there's mild, moderate, severe, and critically ill. There are definitions for this. These are based on the WHO criteria for what the spectrum is. Mild disease, these are people with symptoms. They don't have pneumonia or low oxygen levels. How do you feel? Think about a bad day with the flu. They will have fever, sore throat, muscle ache, feel lousy, feel tired. There could be the sensation of diarrhea, abdominal pain, and fatigue. Now, people with moderate disease, they have clinical signs of pneumonia, and that is fever, cough, feeling like it is difficult to breathe. They could even be breathing faster than normal, but the oxygen saturations are not too low. They're greater than 90% on room air. Some of these people will need to be hospitalized, some will not. Then we have severe disease, and this is a severe pneumonia as evidenced by symptoms, fever, cough, shortness of breath. They're going to be breathing fast. Their respiratory rate will be more than 30. They will be in respiratory distress. Their oxygen levels will be below 90%. They'll need to be in hospital. Then there are critically ill patients. They either have life-threatening organ dysfunction, sepsis, or even shock, and they need to be managed in an ICU. And I'll put some pictures here for you that may help to demonstrate this. So this young lady obviously is not feeling good, but she's at home with her tissues and juice. This fellow is feeling that it's difficult to breathe. He may be able to be managed at home or not. This one has to be in hospital on oxygen. This one is in ICU and is in the prone position and is intubated. Now that we understand the spectrum of disease, how are these persons treated? If you have mild disease and your oxygen levels are not low, you can be treated at home with symptomatic relief. And that would be the usual things that you would do for somebody who has a flu or a cold. Pain medicines, fever reducers, decongestants, cough syrups, a lot of oral fluids, comfort care, warm liquids, soup, for example. They still need to be in isolation, right? Nobody should really be coming in and out of there. You can leave a meal at the door and so on, right? They should be in their own room. It would be great if they could use their own bathroom, like an ensuite bathroom. But if that doesn't exist, they can share the family bathroom, but they should go last, and then the bathroom should be cleaned with bleach and water thereafter. Now, persons with moderate disease, if they have a superimposed bacterial pneumonia, they will need antibiotics. Now, interestingly enough, not everybody who has COVID pneumonia has a bacterial superinfection, is what it's called. They don't have a bacterial pneumonia. And so there was a study at ID Week looking at the chance of bacterial superinfection, either a bloodstream infection or in the lungs, and that was very low. And so you have to be careful. You don't want to give antibiotics to someone with a viral pneumonia. That's very important. I want you all to write that down, not just for COVID, but as a very important key principle for treating patients. Viral infections will not get better with antibiotics. And if you give antibiotics, you stand to give your patient the chance of getting complications from antibiotics. And there are many that we really won't drill down in today because we don't have much time together, but they can get Clostridium difficile infection, which they need to be hospitalized for. That's an infection where the good bacteria in the gut microbiome is depleted. And there would be abdominal pain. They can get GI bleeding. It can actually turn into a toxic megacolon. So that's one thing. They could get an allergic reaction to antibiotics. They could even get kidney failure or liver dysfunction. And so antibiotics, they're good, but they're not without risk. Some people will have adverse effects. And so a viral pneumonia, if there's no evidence that they have a bacterial superinfection, please do not go ahead and treat the patient with antibiotics. You may wonder, how will I know if the person has a bacterial superinfection? Here are some ways to know that. They could have significantly gotten worse. They could have discolored sputum. They could have very, very high fevers. The white cell count may be very high. In viral pneumonias, generally, unless there is some organ dysfunction, the white cell count will not be necessarily higher than 10. There are other ways. There are clinical criteria. You might listen and hear consolidation. A blood culture might be positive. A sputum culture might be positive for an organism, for example. And there are some lab markers that may be more suggestive, but are not absolute. And at your level, you should definitely ask and rely on other members of your team that are more senior that can help you to determine that. And that's also a very, very good point. Well-trained doctors know when to ask for help. We don't make decisions in isolation, especially outside of our skill set. Okay. So for patients who have moderate disease, it is again symptomatic support, fever reducers, pain relievers, rest. If there is a bacterial superinfection, they will get antibiotics. And if they need oxygen, they would be admitted to hospital and get oxygen. Now, there's this question about whether or not you could do oxygen at home. And you could, but you have to be very, very careful, because even in hospital, people who have COVID pneumonia can get sicker or decompensate very, very quickly and need their severity level can change quickly. And they can become unstable, they can become guarded quickly and need to go from a relatively low intensity level ward to, say, ICU, or even a medical intermediate care unit to be monitored more closely. And so I generally don't like to manage patients with COVID needing oxygen at home if there's poor support. Now, how are you going to know that? This is what you have to know, and this is very important. If there's a COVID patient, they started off with mild disease. So our understanding is the first few days, the first week, they could have upper respiratory tract symptoms, cough, fever, runny nose, sore throat, or even muscle and joint pain. And then in the second week, there can be something called the cytokine storm, where they start to get short of breath and need oxygen and support. When the patient says to you, I feel like it's difficult breathing, they may have that handy oxygen saturation monitor that's easy to get now at home. When their sats are dropping below 93%, and in history, when they feel like when they are walking around, like going to the bathroom or doing, getting a meal or getting out of bed, if they feel like they're short of breath or having difficulty breathing, and they have comorbidities or even just those symptoms, they need an in-facility assessment. If that's in an emergency room or a COVID care unit, they need to be assessed, because you need to determine things like how severe is the pneumonia. Imaging may help you with an X-ray or a CT scan. And also how they withstand being exercised. If they walk around a little bit in the ward or in the A&E, is their oxygen dropping low? And a decision would be made about whether or not they need inpatient treatment, or if they're relatively stable with a low risk for decompensating, they don't have a lot of comorbidities, and continue to be cared for at home. That's very important, because like I said, if you send the wrong person home, they can get sick very fast or even die within 12 hours. We've seen that happen. So that's a key thing to know. Know when to send your patient in for further assessment. You should put a little star to that as key points for our talk this morning. Then severe disease. These patients will be in the hospital. They need supplemental oxygen. They will be positioned. The prone positioning changes the physiology of the lungs a little bit and reduces the dead space, and that can help with their oxygenation. I won't drill you down so much at this slide into the in-hospital treatment. And of course, critically ill patients will need to be intubated and mechanical ventilation. They may need extracorporeal membrane oxygenation or ECMO if it is that they have severe COVID-19 pneumonia and they're not oxygenating via perfusion. And the lungs, if they have co-infections, they'll need antibiotics. There's the risk for pulmonary embolism. High-dose anticoagulation seems to help that. They may need IV fluids and even pressors if they go into shock. So that's what you need to know about critically ill patients. Okay, now, here is the part of the talk where we talk about treatment modalities. And this is changing. Here is the take-home message for COVID-19 treatment and treatment of all medical problems when you are a physician. First, let me say new viruses. This is changing. At this time, there's no cure for COVID-19, implying that if you take this treatment modality, you're definitely going to get better and not die. But there are medicines that can either reduce the amount of time in hospital, reduce mortality, help people recover, and reduce the need for hospitalization, basically. That's where we are in the COVID space right now with available therapy. Here is another key point. When there are best quality recommendations, that's what you should follow. And that's important for the treatment of all medical problems, whether it's diabetic ketoacidosis, an acute MI, a stroke. But it takes time to gather that information. So we know COVID has been around for about 23 months now. So at the beginning of the pandemic, there was no widely studied drug that had been given to a lot of patients. So the gold standard of care or clinical trials of a medicine is something called a randomized double-blind clinically controlled trial. Okay, that's the best standard. And you should have heard that before in your basic medicine training, basic sciences. What does that mean? It means that Dr. Forbes can't say, take Cerecy, you're gonna get over COVID. It means that Dr. Murmoxie can't say, no ivermectin, that's how you get over COVID. It means Dr. Sears can't say, no, forget that. Take hydroxychloroquine. No prejudice, just giving examples, okay? So that's how we know. And so the double-blind clinically controlled trial is one where the modality is given, there's an independent review board, the doctors or the healthcare workers may not necessarily know what the patient is getting, so that biases can be removed, and that there's objective information that it works, right? It either gets you better faster, you don't die as much, etc. Okay, but it takes time to get that. And sometimes we don't have that information. And so sometimes we can use expert guidelines. And there are panels sometimes where we don't have good information, where a number of specialists, because everyone has their skill sets and certainly putting your heads together is helpful, may say, okay, let's review the information we have and come up with a guideline and how good is the evidence. And so that's what you really are looking for in the way we practice medicine in this day and age. Okay. And so you can use expert guidelines. This is something I modified from the ID Society guidelines, which I like to use. There's also the World Health Organization Living Update on COVID-19 that has very good information too. And the NIH also has a treatment guideline for COVID-19. And I would say that there is some overlap, but generally there's agreement on these modalities. So you just need to know this in brief. You don't need to remember all the names of these new medicines, but this is what you need to know at the MBBS level. There are corticosteroids, which can help for patients that need oxygen supplementation. Okay, there is a benefit to that. And so then corticosteroids like dexamethasone are either given by mouth or IV in patients that need to be hospitalized with low oxygen levels. And so you'll see here the little green check marks. I have at the top ambulatory patients, mild patients that are hospitalized. For example, they could be there, for example, they need an appendectomy. Then there are severe patients with COVID pneumonia and critically ill patients, and we just discussed that. And then there's the post-exposure prophylaxis that will come under prevention. We'll come back to that, okay? So corticosteroids are used in people who are hospitalized that need oxygen, basically. And then, sorry, I have a typo on that second one. It's tocilizumab. The first L is not there. That is a repurposed rheumatoid arthritis drug. It's an IL-6 antagonist, and that has anti-inflammatory properties. Remember, I was talking about the cytokine storm in the second week? That can be used for hospitalized patients whose oxygen level is low, okay? And that seems to be very helpful. And there is another drug like that, saralimab. Then there's remdesivir, which is an antiviral that was studied. It can be helpful. It reduces the hospitalization in patients with severe non-critical COVID pneumonia, but they're hypoxic. They need oxygen. This is not really recommended in people who need to be in ICU or intubated. And then there are these monoclonal antibodies. That is what is in lines 5 and 6. The first one is the drug that's called Regeneron, casirivimab, and then there's bamlanivimab, and they are given in combination with other monoclonal antibodies. And there's an important thing to know about these. So, sorry, there's an ambulance going by at my office. Monoclonal antibodies have a role in the treatment of COVID-19. And those people who are positive, they have mild disease. So that means they're ambulatory. They're not in hospital, they're at home, they don't feel too bad, but they have a risk of decompensating. Then they should be considered for this agent, and they have a risk of doing poorly if they get severe COVID-19. They should be considered for this agent. And there are persons, for example, over the age of 65, they're diabetic, they have lung diseases, they're on long-term steroid treatment, they're obese, they have a neurological problem, they can benefit from this. It should not really be given in people who are severely ill or critically ill already. There is room for discussion for those people who are hospitalized for other problems and have a risk for decompensating. And there's good evidence for this. And then the post-exposure prophylaxis for those people who don't have COVID yet, but if they got COVID are at risk for decompensating and they were exposed and had a high risk exposure, there is a role for Regeneron. It is supported by guidelines, okay? Now, not everyone can get remdesivir. You can't give it in people who have liver dysfunction or who start to have abnormal LFTs after getting remdesivir. And so you can use other medicines. These JK inhibitors, baricitinib and tofacitinib, can be given. And sometimes they're even given in combination with remdesivir. You don't need to memorize this. It really shouldn't be on an MBBS test, but you have to have some knowledge of it. Okay, now I was going to go into the guideline document, but we are actually running a bit out of time. And I don't think that you need to know that at your level. And so if you have any questions, we can take it now.
Good morning, Dr. Forbes. Oh, sorry, Dr. Moxie.
Continue.
Student doctor, is that student Dr. Lyons?
Yes, ma'am. I wanted to ask this question a little earlier. In
Okay.
terms of preventative measures, do you recommend double masking? I know there are two schools of thought. I've heard that the outer mask can sometimes affect the fit of the inner mask without you realizing.
Yeah, that's a great question. And I do to an extent. So outside of the hospital, say, for example, you have a homemade mask. They're not perfect. You know, each mask will be a little different and it will allow some air to filter. Even the surgical mask only filters about 40 to maybe even 60% of some of the particles. And so in some high risk contexts, for example, you have to travel and you have to be in a group for a certain period of time, it's crowded, I would actually recommend double masking. And so here's some key things. If you're going to double mask, you should make sure that the mask on the bottom is not affecting the fit of the mask on the top, or that it's not causing leak, or it's work even worse because it's bunching up and then air is leaking in on one side. And there are other things. So you have to be able to breathe through it. If it has plastic material or some linings, if you cannot breathe, then that's not going to be a good thing. And so, but in the healthcare setting, the N95 mask, they're actually supposed to be fitted to your face, the size of your face and things about your facial structure. And employee health is supposed to do that. They come in various sizes. They do have these universal ones now, but really and truly, if you put a surgical mask under an N95, it's going to affect the seal. And so that may actually increase your chance of breathing in air that has COVID in it. And then there are other things. For example, males with facial hair, that can affect the seal of the medical mask. And so for if you're going to do an aerosol generating procedure, if you're going to suction your patient or intubate your patient, what you really want to have on is a properly fitting N95 mask and a face shield, eye protection. So it depends.
Thank you, Dr. Forbes.
You're welcome. Any other questions?
Hi, Dr. Forbes. Excellent presentation. This is Abigail.
Hi, Abigail.
I have a question in regards to prevention. I know that there are some doctors who have been pushing for persons to focus more on prevention rather than contracting COVID in terms of daily intake of supplements. Is there any recommendation approved, I guess, here for supplements such as zinc, vitamin D for daily ingestion?
Okay, that's a great question. I'm glad you raised that. So there's a few more things we do need to talk about this morning in your class. So let's talk about vaccines for a minute, okay? Let me, I think I stopped sharing my slides, right?
Yes, ma'am.
But I did this presentation for a non-medical group 2 days ago. Let me show you this one instead. Being healthy is an important part of not getting disease. And I mean, that sounds like a no-brainer, but really and truly, there's a lot that goes into being healthy. So a healthy diet, having enough of the recommended daily allowance of vitamins. If you don't get it in your food, you should take a vitamin supplement. Zinc maybe can help, and high dose vitamin C, maybe it helps with viral infections, but it won't necessarily, as healthy as you are, you can still get COVID. The healthiest people can get COVID and even die of COVID. And so, yes, it's important to be healthy, and we have to think about these things holistically, but there's nothing that is 100%. And so when you think about infections in the grand scheme of things, infection prevention is a risk reduction strategy. It's not one thing because there's no magic bullet that's 100%, mostly in most infections. You follow me? HIV, another one of my passions. There's no magic bullet. You could use a condom, it could break. You could use PrEP. PrEP is not always efficacious. You can say, I'm not going to have sex. It doesn't work very well. You understand? So you have to think about overall ways to reduce risk. COVID is no different. So vaccines, they're helpful, but there can be breakthrough infections. Vaccines are very, very effective, but there can still be breakthrough infections. Let's take a look at the slide. These are the vaccines. I think you all know all about vaccines by now, so I didn't want to drill you down into them, but these are some of the vaccines that are available. Let's look at the efficacy. In the clinical trial, not the real world where we have emerging variants like Delta, the efficacy was 62 to 90%. And the efficacy of Sinovac is 50 to 70%. mRNA vaccines, the efficacy was upward of 95%. And Johnson & Johnson, that efficacy is a lot like Oxford AstraZeneca. And so you will see that vaccines do help significantly to reduce hospitalizations and deaths. This is our local data that I presented at Research Day, that Hilary DeVoe presented at Research Day for our study. These are the COVID admissions. You can see the vast majority of these people were unvaccinated, 96%. Only 1% of fully vaccinated people were admitted and 3% of partially vaccinated in 1,001 patients. And this was the COVID deaths. You see almost 95% were unvaccinated. So there's no doubt that vaccination works. It does do what it's supposed to do. And the CDC, for example, has a big study that shows, this is based on 3 studies in the MMWR, Morbidity and Mortality Weekly. Those that are unvaccinated, they're 4.5 times more likely to get COVID, 10 times more likely to be hospitalized, and 11 times more likely to die from COVID. Okay, so to answer your question, Abigail, briefly, vitamins and other things will not be fully protective. That you have to look at risk reduction and look at the data, and the data is clear on that. Also, those that have had COVID, the immunity can be transient, maybe about 3 months. And there are studies that support that those that have had COVID and are vaccinated are far less likely. I think it's 5 times, they're 5 times, rather, let's say it the other way. Those that had COVID and are not vaccinated have a 5 times higher risk of getting COVID again than those that are vaccinated. Okay, so a few other things that I want to mention, what not to do. All right, let me stop sharing this before I see if we could cover this before we go to clinic. All right, so how do you know what not to use? Okay, now I've told you how to process the information to know what to do, and that's based on the best quality recommendations, right? Data. I am going to show you my ID Society guidelines so that you can understand this, because 6 months from now, treatment can be different, and you will need to know how do you interpret it. People are going to be asking you, because your student doctors, well, what about that? Can I use hydroxychloroquine? Should I use ivermectin, for example? All right, so bear with me while I share my last screen. Here it is. So I hope you're seeing the ID Society guidelines. Is that what you're seeing on your screen? Yeah?
Yes, ma'am.
Okay, all right. So this is how guideline documents are structured. And you have to know, how do you read stuff? Because if you went into Google now and put COVID treatment, there'll probably be hundreds of thousands of hits that come up. So how do you say, okay, yes, no, this is accurate, good medical information? Well, Dr. Forbes said, or, that's not the point. It has to be summarized and objective. So these are the guidelines I like to use. Like I said, the WHO has something similar, and so does the NIH. So here, there is the guideline for treatment, and they tell you the process by how these guidelines were written and who's on the board and how often it's reviewed. And then there's an overview. It just basically looks like a table of all those drugs. I summarized it to make it easier for you to digest. And then it talks about the summary. It talks about the methods and the search results. See, this was developed using the GRADE approach. It's going to tell you the quality of the recommendations: high quality, good evidence, moderate quality, poor evidence, for example, expert consensus. Okay, let's talk about some of these things. Remember hydroxychloroquine and all of the hype around it, for lack of a better term, with it was politicized. There were persons who came out and said it should be used, it's a cure, it's a conspiracy. And so it talks about the studies and why it might work. So why might it work? It talks about what it is, the class of drug. It's an anti-malarial. For example, they've been used in autoimmune diseases. There is theoretical evidence that it could have antiviral properties. It demonstrated in vitro activity against SARS-CoV, but there was variability between the studies. Okay, so there is bias in studies. Sometimes we so desperately want something to work that we maybe enroll people who aren't likely to die or get sick from COVID in the first place. And so they'll tell you the summary of the evidence. There were 8 randomized controlled trials and cohort studies, and they will tell you if there was a benefit, there was a trend, but it wasn't statistically significant. All these things you're going to learn in your epidemiological class, your epidemiology class, and they talk about the potential harms. And so some may have had a longer time to hospital discharge, for example, and there could be severe adverse effects, and there were GI side effects. And then the panel will tell you what the conclusion is and other considerations. So here is what the panel agreed to. There was overall certainty of evidence against treatment, which was moderate, and it was due to concerns with imprecision around the risk for a trend toward harms for increased mortality. So they're basically saying that there was a trend toward harms and there was a trend toward increased mortality. And so therefore the panel recommended against use of hydroxychloroquine alone or in combination with azithromycin in hospitalized settings, because as the certainty of benefits like mortality reduction are highly unlikely. And they will review it if there's additional randomized control trials. So they don't recommend against the use, okay? So it's not based on opinion. So that could be the best lesson from today. Please use guidelines if you can. Ivermectin. Now that's the new hot topic. Why is it being considered? It's an antiparasitic drug. It has been reported to have in vitro activity against some viruses, including SARS-CoV-2, but we don't know if it has therapeutic utility. Okay. Now here, in vitro activity requires concentrations higher than those that can be achieved in the human plasma and lung tissue. That's saying you would have to take more than the usual dose, and that dose is not safe to take. Okay. Use caution. The other coronavirus, the MERS coronavirus in Saudi Arabia, lopinavir, was supposed to have activity, but it actually increased the time for viral shedding. It doesn't always do what you think it will do in the actual clinical trial. So it's important to have trials, okay? So then there is a summary of evidence. There were 15 studies, different age ranges. You can go back and read this on your own because we're running out of time. So the benefits, it failed to show a reduction or increase in mortality among patients with COVID-19. And there was no meaningful reduction in mortality among patients treated with ivermectin with COVID-19. And it did not demonstrate a beneficial or detrimental effect on symptom resolution or viral clearance at day 7. And the evidence is uncertain. And it seemed like it was fairly well tolerated, but they couldn't exclude the potential for adverse events in hospitalized patients and serious adverse events. And the panel concluded against the use of it in hospitalized patients unless it's in the context of a clinical trial. And so that is some of the information on treatment. I hope it makes it a little more clear in terms of how do you know what to use, how come we're using this and that. In the Bahamas, we have remdesivir and tocilizumab. We had some monoclonal antibodies, a few that were donated. We're trying to expand our treatment arsenal. We do have steroids. So my time is actually up. Are there any more questions before we wrap up?
I had one. There is a new approach here that Dr. Julia Hepburn is doing, photodynamic therapy and methylene blue in early COVID-19. It's definitely not hospitalized patients. It's way up front, early symptoms. And she has been getting good results. Of course, anyway, she studied it. I don't know if she's published, and I think she has, in a group using this Luminova therapy system. So, you know, I know, I don't know if it would have made it into the infectious society guidelines. I don't see anything there, but that's something that's happening locally. So
Know about it.
yes,
So there is, sorry, I'm just sending a little apology that I'm running a little bit late for clinic, so my team knows where I am. So photodynamic therapy is something that is being studied for COVID-19. If you look at that, there are studies, for example, in Fort Lauderdale and some North American hospitals and in some European spaces. There is the attempt to do clinical control trials regarding that. And there's no clear data at this time. And so what I would say to you, Dr. Moxie, and others is the gold standard is a blinded, randomized control trial. So to be clear, Dr. Hepburn did put forth to the COVID ethics board, of which I'm a member, a proposal to do a pilot, of which she was granted permission to do a pilot. And she came back and reported, however, the report is not in yet, and it does need to demonstrate objectivity, lack of bias, and other objective information that there's either a benefit in terms of recovery and other things, which I don't think we've heard of yet. And I would say that we've come a long way in the medical field, and I think it's good. And because I'm so happy that you are having this community health rotation for students, because we have to understand, why do we do the things that we do? When someone has a myocardial infarction, why do we say aspirin, a beta blocker, ACE inhibitors, antiplatelet agents? It's not because I say so, or the best doctor in the world, in your opinion, says so. It's based upon data that patients have a mortality benefit, or it reduces their chance of having a recurrent event, or there's a symptom improvement. And that is how we must practice, because we've moved away from, yes, medicine is an apprenticeship, but we've moved away from saying, oh, because I think so. And so we would await that objective evidence, and it's not a standard therapeutic modality right now. I've shown you the effective therapeutic modalities that are understood to be how patients are treated.
Because, to bring it sort of to the reality, in the medical association physicians group, I mean, we have huge debates. It started with hydroxychloroquine, that died down, then ivermectin flared up, and
Yes. And so again, I think that it is very important to say, and for this next generation of Bahamian doctors, and I feel very, very strongly about it, how do you know how to process this information? Who do you listen to? How do you figure this out? There's a lot of information out there. And so really and truly, if there is an expert, good quality, objective guideline document with good data and evidence, that is how you should proceed. And certainly there are a lot of voices, some are loud, but it's not always correct. And so I would say that that's
the way to go. Correct.
medical practice. And however many debates, it takes up a lot of time, but it doesn't necessarily mean that the patient is going to get better. And on the other hand, we can do harms. And so, it would be great. I wish we could, steward this better. And COVID has really showed us how much misinformation there is and how damaging it can be. So that's all I could say to you, student doctors. You're young. You have something called neuroplasticity. How you learn is going to have an important impact on the rest of your medical career. Learn it right the first time. Yes, Dr. Sears?
I just wanted to chime in and say I really appreciate it, particularly the end of your talk. And I think a part of, the student doctors understanding why you're using or how these studies are run is like, there's a gap between what I, as a researcher at the bench, do, like when I put a drug on cells in a dish and see a level of activity, there's a huge gap between that and taking it to the clinic. And so there are logical reasons for why people initiated those studies with hydroxychloroquine and ivermectin, right? Because we saw in vitro activity, right? They saw activity in cells in a dish, but that's very different from what's going to happen in a person. And I think people need to sort of understand and appreciate that, that activity is not always going to transfer over, and more times often than not, it won't, right? Because we're dealing with cells that have been transformed. They're not normal cells by any, so you can learn something, but don't assume that information will perfectly map onto treating somebody in the clinic.
Yes, very good.
Thank you very much for that. I wish you would say that for all of the rest of the Bahamas to hear, especially the doctors.
Yeah.
Yeah.
Alrighty, you all, it is always a pleasure. I have got to run and go to chest clinic.
Enjoy your weekend and take care. Bye-bye.